we prepare 5 lectures. Each lecture will be continued for 15 minutes. After all 5 speeches, we are going to have discussion time. That is also about 15 minutes. Let me introduce the first speaker, Dr. Andrei Pop. He has been a Chief Interventional Fellow in William Bowman Hospital, Royal Oak, Michigan. And he is a system head, Ascension, Illinois Structural Heart Program. And title of his lecture today is Lifetime Management of Aortic Stenosis, TAVI in the Young. Andrei, please.
Thank you so much for the kind introduction, and thank you for the invitation. Lifetime management is a very important topic to me, and in the United States, it's something that becomes more and more discussed, because in the United States, even for people under the age of 65, almost 50% of patients get TAVI. This is a population where the majority of patients are bicuspid, and the data for the treatment of patients with age less than 65 is very limited. As you know, we have a lot of options for treating aortic stenosis. We have surgical AVR with a mechanical or bioprosthetic valve. We can do root enlargement or root replacement, although it's done rarely. And we can use high frame or low frame valves. Question is, does surgical AVR still have a role in 2023? And I would argue that the data for surgical AVR is actually excellent. This is data from the recovery trial showing 3-year survival of 100% basically, so they had 0 mortality. The surgery can fix leaflet calcifications, can deal with calcium in the outflow tract, can deal with coronary heights, can do many things. They can extract the leaflets. So surgery certainly needs to be a very important part of the discussion. How about mechanical aortic valves? They theoretically last forever. They have a slightly higher risk of infection. And if you're under the age of 54, you actually get a survival benefit from a mechanical aortic valve. The problem is that in the United States, people are not putting in many mechanical valves because of the need for anticoagulation. Patients simply do not want them. So how about these fancy surgeries that can be done and unfortunately are done very rarely? A surgeon can enlarge the aortic root or can replace the entire aortic root and reimplant the coronaries. If you are in an experienced center with a good surgeon, your outcomes should be similar to standard AVR, even though pump time and blood loss will be increased. Unfortunately, this is being done very rarely, even in big centers in the United States. So how is the decision made on who's going to get surgery or who's going to get one of these fancy surgeries? And the answer is, most of the time the decision is made by the surgeon intraoperatively, relatively in a vacuum. A lot of surgeons who might be willing to do this type of surgery are going to be reluctant to do it on an ad hoc basis. They would like to have their senior partner around, they would like to have somebody else, they would like to have prepared differently. And the good news is that we can prepare the patient and we can find out ahead of time whether this will be necessary. This is data showing that if you do a CAT scan on patients, you can very accurately predict the size of the valve that will be implanted. And you will either estimate correctly or you will overestimate. You will never underestimate the size of the valve that the surgeon will put in. And once you have that information, you can estimate the patient's risk of patient-prosthesis mismatch. And if you know that the patient is at high risk of patient-prosthesis mismatch, then you know that potentially they need an aortic root enlargement. So how about TAVR? The long-term durability is somewhat limited. We don't have a lot of information for that. We think that the long-term durability is similar as with surgical AVR. But the data is limited in duration. We have good data from bicuspid trials, a lot of it originating in Asia. There's a lot of experience with that, especially here. The problem is that most patients who are included in bicuspid trials go through a screening process, and the exact details of the screening process are not clear. There is no clear quantification method to tell you that this patient should have a TAVR or should not have a TAVR. There's a lot of times when it says, you know, excessive calcium, excessive Raphe calcium, but what excessive means nobody tells you. The other problem with TAVR is that we've been dealing with a lot of older people, and complications that may be acceptable in older people are not going to be accessible if you're dealing with 50-year-olds. We know that pacemaker and aortic regurgitation after TAVI is not a good thing. Recently, we found out that even with mild aortic insufficiency, your outcomes are bad. So avoiding pacemakers and perivalvular AI is important if you're doing young people. We know that coronary access can be a problem, and we have to be cognizant of that. If you have an 80-year-old who has no coronary artery disease, it's very unlikely they're going to get coronary artery disease in their lifetime. With a 50-year-old, there is a good chance that you're going to have to deal with the coronaries in the future, so we have to think about that. So how about TAVR in surgical AVR? We do a lot of this in the US. These are the risk factors that predict difficulty in putting a TAVR in a surgical AVR valve. We can do all these fancy things, balloon valve fracture, basilica, unicorn procedure, snorkels, but I would argue that these do not belong in young people. If you're young and you need a basilica, you're probably better off having surgery and having definitive repair or replacement. Certainly, these techniques have a role in older people. They have a role in people who have no other options. But again, in healthy young people, they shouldn't be used. The other thing that I hear a lot is, well, this person may be 70 and maybe they're not going to live that long. Why do we have to bother about a second valve? The reality is that a second valve may happen a lot earlier than we think, because there can be implant problems. The valve can be placed too high or too low. It can be underexpanded or overexpanded, and all these things affect valve durability. Also, patient compliance. We had a patient, for instance, who did not take any antiplatelet therapy and was lost to follow-up for 2 or 3 years, came back with a severely degenerated valve that had to be replaced. So how about TAVR in TAVR? We know the risk factor for coronary occlusion with TAVR in TAVR. These were well published and well described. This is one of the seminal papers from Okiai telling you how to assess the risk of coronary obstruction and sinus sequestration. Commissural alignment can be done with self-expanding valves. You fall within about 30 degrees. The problem with commissural alignment is that the coronaries are not always aligned with the commissures. And especially in bicuspid valves, the coronaries may be somewhere where you don't expect them to be. So what we need in the future is coronary alignment rather than commissural alignment. So how about SAVR after TAVR? This tends to be a bloody proposition. We recently have data that shows that the outcomes are quite bad with valve extraction. All the bad things happen. Prolonged ventilation, stroke rate, mortality is increased. Certainly TAVR in TAVR is going to be safer than TAVR explant. And a lot of times you need to repair the ascending aorta or you need to replace the mitral valve. So probably if you're going to plan on a patient having an extraction, you should go with a smaller valve, a smaller frame valve. So a couple of case examples. This is a 57-year-old who had a 27 millimeter perimount placed 5 years prior. The valve has now failed. He's 57. And he has no option to put in a TAVR valve. The coronaries are way too low, as you can see, less than 6 millimeters for the right and 6.5 millimeters for the left. And the distance to coronaries is about 1 millimeter. Can you do a basilica in this situation? Absolutely you can, but what are you going to do in 5 or 10 years when it fails again? So I would argue that this patient needs not only surgery, but he shouldn't have just a valve replacement. He should actually have his anatomy addressed, so next time around when the valve fails, he can have a TAVI in there. Or just put a mechanical valve. But this is an example of where the surgical technique really needs to be adjusted for future TAVR in SAVR. This is another case of a failed 34-year-old 34 millimeter evolute with severe central AI. You can see that the valve to coronary distance was tight and the coronaries arise below the risk plane. If you try to put a valve in there, you have a high risk of occlusion. So you have to take these things into account, especially in younger people. So how do we put all this together? Well, the older I get, the more I want my procedures to be boring and simple. I think surgery is more complex than TAVR, but can be very safe and reproducible in many patients. I think that complex procedures should be avoided unless there is a need to do something very complex. And you have to be knowledgeable of what your center can do and what the community can do. If you need to do complex surgery like an aortic root enlargement or replacement, you're better off doing it at a young age than waiting until the patient is 70 or 75. I think the initial valve choice is very important. You have to take into account not only the patient's immediate risk from the procedure, but you have to look at their entire risk over a lifetime. So the risk of, let's say, 2 TAVI and 1 SAVR, or 2 SAVR and 1 TAVI. And the problem is that the current risk calculators that we have are very limited. For instance, the STS PROM calculator does not take into account any sort of root enlargement or root replacement. And the TAVR risk calculator does not take into account basilica or TAVR in SAVR or TAVR in TAVR. So these are my proposed principles, and we're trying to put them in a paper and publish it soon. I think ideally everybody would get only 1 lifetime sternotomy maximum. I think that a CTA and multidisciplinary valve team consultation should be offered to all patients considered for bioprosthetic heart valve, not only for the patients considered for TAVR. I think it's much more important to know what the life expectancy is rather than the age. Coronary access and avoiding pacemaker placement and perivalvular AI are very important. We need to figure out this lifetime risk rather than the immediate risk, and we have no tools at this point for that. And in certain patients, it may be reasonable to start with TAVR first, planning to allow for extraction or other procedures in the future. And if you're going to explant, probably use a low frame valve. Avoiding high-risk procedures is important in all cases. So this is how I put it all together. Everybody needs a CTA. There's no ideal sequence of SAVR versus TAVR. And you can start with either valve depending on the anatomy. You need to know what the anatomy is, and that's why the CTA and the valve team decision is critical. So this is a proposed pathway that I'm working on together with a team from Columbia in New York. So I think anybody who's got a life expectancy of less than 5 or 6 years really shouldn't be considering surgery unless there's a good reason for it. If your life expectancy is less than 5 or 6 years, then you really should be considering TAVR, and if TAVR is not an option, then you unfortunately have to go to palliative care. If the patient is a surgical candidate, or if the patient has reasons to have more extensive surgery, then you have to determine whether their anatomy permits future TAVR and SAVR and quantify their lifetime risk. Once you're looking at a patient that you're considering SAVR, what we propose is basically first looking at the potential for patient-prosthesis mismatch. If there is potential for patient-prosthesis mismatch, then you have to examine whether aortic root enlargement or replacement is an option. If there is no potential for patient-prosthesis mismatch, then you have to evaluate the potential to have TAVR and SAVR. Now, if you're considering a patient for TAVR, similarly, you have to estimate their level of risk, and this is very subjective. We have no calculators for this. And once the level of risk has been quantified, then you have to look at whether the patient will be able to have TAVR and TAVR. So again, looking at a 57-year-old that I showed you earlier with the 27 millimeter perimount, you could come up with a calculation something along these lines. So basically, you could say the patient could have had a mechanical valve. This is their lifetime risk. The patient could have now a mechanical valve the second time around. This is their lifetime risk, but they have to take anticoagulation. Or you can factor in all these various combinations of TAVR, SAVR, whatever. The problem is that we don't have a calculator for this yet, but I think that this is the approach that will lead to a solution in the future. So with that, thank you very much for giving me the opportunity to present, and I'll take any questions.
Yeah, discussions will be done after all the lectures.
Okay.
So next topic, will be done by Dr. Do Yun Kang. His center performs most largest number of TAVI in Korea. So actually, he and his team performed the antithrombotic regimen trial after TAVI recent years. So his title is Ideal Antithrombotic Regimen after TAVI in patient without need for oral anticoagulation. Dr. Kang, please.
Thank you for your kind introduction. I'm Dr. Do Young Kang from Asan Medical Center. My topic is the ideal antithrombotic regimen after TAVI in patient without need for oral anticoagulation. The depth regimen in past TAVR RCT series used the conventional regimen with the 6 months clopidogrel and aspirin indefinitely. And the decision was based on expert consensus that each like a stent. And the rationale for treatment was to decrease stroke or MI risk. However, there raised some concern about the subclinical reflex thrombosis after 2017 that was published in Lancet about the in CT, MDCT follow-up of the TAVI patient showed the reflex thrombosis, and it showed the dynamic pattern of the reflex thrombosis with anticoagulant therapy. It progressed to the hypoattenuating reflex thickening, and some patients with the hypoattenuating affecting motion and regressed with the anticoagulation. In partner 3 cardiac CT sub-study with about 435 patients showed that about 13% of the TAVI patients showed heart at 30 days and 28% at 1 year. And also it showed the dynamic patterns that appeared and disappeared by the medication or the patient situation. However, the important thing is that the number was still small, but in the patient with the heart showed higher risk, higher trend of the risk of the stroke, TIA, and retinal artery embolism, like thromboembolic event. In our center's data, sinus valsalva thrombosis was also shown in Asan TAVR CT registry. In 9 of the 190 patients underwent a CT scan after TAVR, subclinical embolic stroke noted in 3 patients on brain MRI, and all 9 patients with the sinus valsalva thrombosis was on depth and without anticoagulation. So there raised some concern that subclinical reflex thrombosis would make some cerebral thromboembolism or stroke or TIA related to thrombosis, and also would it make some reflex degeneration earlier. And we know that oral anticoagulation can reduce the reflex thrombosis, but we do not know that it would affect the patient outcome, and oral anticoagulation would improve patient outcome with a thromboembolic event. So this is a new concern about stroke or reflex thrombosis versus bleeding in old TAVI patient. So many RCTs evaluated antithrombotic regimens after TAVI, and almost all trials finished, and we now have the result. And today's topic is the patient with no indication for oral anticoagulation. I will review the first part. The antiplatelet and anticoagulation, two strategies were tested. First strategy is the antiplatelet regimen with a single versus dual. First trial was the ARTE trial that was published in 2017, and with a small number of the patient, 111 versus 111. And it showed the low bleeding event in the aspirin and similar stroke or TIA, MI, and death event in both groups. It's the definite result that the weaker antiplatelet can make lower bleeding. And this is the combined primary endpoint with the bleeding or ischemic event, also showed the trend of the lower in aspirin monotherapy group. The bigger trial, POP-TAVI trial, was published in NEJM 2020 with the 2 groups without indication of oral anticoagulant and with indication of the anticoagulant. And the cohort A without anticoagulant indication shows the lower bleeding risk in aspirin group and similar severe mortality ischemic stroke MI in both groups. So in the low intensity antiplatelet therapy with the aspirin monotherapy could be justified because of the lower bleeding rate. However, the trials was not fully tested for the ischemic outcome. And the anticoagulation therapy also was tested with the NOACs. The anticoagulation plus minus antiplatelet versus dual antiplatelet was usually tested because the dual antiplatelet therapy was the standard at the time of the trial, the planning. First is Galileo with the rivaroxaban, and second is the Atlantis with the apixaban, and third is Adaptavir with the edoxaban. And Galileo trial randomized the TAVI patient with the rivaroxaban plus aspirin, and after 19 days, used the rivaroxaban 10 mg QD monotherapy. And other group used the DEPT and then aspirin monotherapy. The primary efficacy endpoint was the thrombotic events and death and stroke, and primary safety endpoint was about to measure disabling or life-threatening bleeding. And the trial endpoint, efficacy endpoint, even the thrombotic or ischemic event showed worse event in the rivaroxaban group with a hazard ratio 1.35. And primary safety endpoint, the bleeding event, showed a trend of the increase in the rivaroxaban group. All-cause mortality was higher in rivaroxaban group. In the subgroup, a sub-study of the 4D CT scan at 3 months showed that reduced reflex motion and reflex thickening was better in rivaroxaban group. However, the clinical outcome was not related to this improving in reflex motion. The second trial was Atlantis with the apixaban. It was published in 2022, and it randomized 1,500 patients with a stratum with a one indication of oral anticoagulation therapy versus no indication oral anticoagulation therapy. I will leave this stratum 2 that the patient without indication of the oral anticoagulation therapy was randomized to apixaban 5 mg versus DEPT. And the primary endpoint was a composite of death, MI, stroke, systemic embolic event, plus the intracardiac or bioprosthetic thrombus and other thrombotic event, plus major bleeding over 1 year follow-up. The primary endpoint was similar between groups. Because this was a superiority trial of the apixaban group, the primary endpoint was not met. And the subgroup analysis in the patient without indication of the oral anticoagulation therapy over 1,000 patients showed a trend of the lower event in apixaban group, but was not statistically significant. The outcomes in stratum 2 post-hoc analysis of about 1,000 patients, primary endpoint outcome looks a little bit lower in apixaban group. However, you can see that death, especially for the non-cardiovascular death, was higher in apixaban group. And valve thrombosis was lower in apixaban group, but other event was not different. So all trend shows that the anticoagulation decreases the reflex thrombosis. However, it's not related to the better clinical outcomes. So we evaluated the Adaptavir trial we think that more weaker or softer NOAC with the edoxaban. It was the Adaptavir trial that was published last year. And the primary objective of the Adaptavir trial was to investigate the effect of edoxaban compared to DEPT for the prevention of reflex thrombosis and potential risk of cerebral thromboembolization and neurologic outcomes. We randomized 220 patients because the enrolling the TAVI patient was difficult at the time, and the number of TAVI was very small. We enrolled a small number of the patients and used the surrogate outcome of the 4D CT at 6 months and serial brain MRI and neurological or neurocognitive functional test at baseline and 6 months. The patient was randomized by edoxaban versus DEPT with the aspirin plus clopidogrel. The inclusion criteria was the symptomatic AS underwent successful TAVR, and key exclusion was the establish the indication or contraindication to the anticoagulation or depth therapy. Study endpoint was the surrogate endpoint, incidence of the reflex thrombosis on 4D volume random CT at 6 months. A secondary endpoint was the presence and number volume of new cerebral lesions on brain MRI and serial change of the neurological or neurocognitive assessment by the NIHSS, MRS, and MOCA, the grading system. And also we gathered the safety and efficacy clinical outcomes. The patient was enrolled in 5 centers in 3 countries, including Hong Kong and Taiwan. And sample size was calculated by the superiority, the hypothesis of the edoxaban group versus depth. We screened more than 700 patients, and 235 patients was randomized and followed. The mean age was 80, as usual in the TAVI trials, and STS score was 3.3 in the mean that was low risk patient, and many patient has the prior PCI history, but because the patient had not recent PCI that does not have the depth indication, absolute depth indication. And the major valve was balloon expandable valve, and the post-TAVI echo parameter shows that the acceptable range of the echocardiographic characters. And the post-TAVI CT, brain MRI, and neurologic assessment was performed in more than 90% of patients. We did a very hard job. And this is the primary endpoint of the valve reflex thrombosis in ITT population, will show the trend of the lower in edoxaban group, but not statistically significant. And PP population, it was a bit significant. And reduced reflex motion and reduced reflex motion severe in also ITT and PP population showed a trend of the lower in edoxaban group. However, it was not significantly different because of the low patient number. But MRI endpoint did not show any trend of the better in edoxaban group. The new cerebral lesions and median number of total new lesion and median volume of total new embolic lesion did not show any benefit in edoxaban group. And also neurological and neurocognitive endpoints did not show any difference between groups. And importantly, the severity of heart with the extent of new lesions on brain MRI did not show any correlation. Also, the heart severity and decline of neurological assessment also did not show any correlation in analysis. The clinical outcome also is only 6 months outcome in small number, but did not show any difference between groups. The trial was on open label, and it can potentially subject to reporting and ascertainment bias. And also our trial adapted surrogate imaging endpoint. Therefore, our study was underpowered to detect clinical relevant difference. And follow-up period was relatively short, and also the long-term effect of the reflex thrombosis or antithrombotic strategies on valve durability is unknown by this trial. And our findings cannot be directly applied in patients with the clinical indication for oral anticoagulant therapy. So this is conclusion of the ADAPT trial. The overall incidence of the reflex thrombosis on CT scans was less frequent with the edoxaban therapy, but it did not reach statistical significance. The incidence of new cerebral thromboembolism on brain MRI and new development of the neurological dysfunction were not different between two groups, and we could not find causal association of the reflex thrombosis with temporal related changes in new cerebral lesions and the clinical neurologic outcome. This is a summary of the previous RCTs for antithrombotic therapy after TAVR, and that all trials shows no benefit of the strong regimen compared to weaker regimen with a CEPT. So POP-TAVI Cohort A adapted conservative design. However, it's not compelling for clear decision making. Galileo showed triple hazard, death, thrombotic complication, bleeding with rivaroxaban plus aspirin over depth. Atlantis showed that apixaban has no benefit over standard of care post-TAVI. Imaging outcome favorable but clinically inconclusive. ADEPT TAVR showed no relationship of valve thrombosis and cerebrovascular embolization and associated neurologic or neurocognitive dysfunction. Why RCTs for TAVR patient failed? In theory, if we use the anticoagulation, the patient would be better, but no result. Even no antithrombotics after TAVR was acceptable in Ocean TAVR registry. In patient without antithrombotic the regimen showed similar bleeding and net adverse clinical outcome in old age TAVI patient. So the now guideline recommends for patients with the TAVI, aspirin is recommended in US guideline, and low risk of bleeding, short-term depth is recommended in some patient. US guideline is more simple. In patient without OSE indication, lifelong single antiplatelet therapy is indicated, and routine use of oral anticoagulation is not recommended in TAVI patient. So this is a take-home message from my lecture. Subclinical reverse thrombosis has not been proven to affect the clinical outcomes per patient underwent TAVR. And this imaging phenomenon should not dictate the strong antithrombotic therapy for its prevention. And if subclinical reverse thrombosis is not clinically relevant phenomenon, less is more concept of the antithrombotic strategy would be optimal management for TAVI patient, especially for older patient. And this answer is adapted in current guideline with the septum monotherapy. However, long-term clinical impact of reverse thrombosis and the impact of the use of NOAC for those patients need further investigation in younger population. Thank you for your attention.
Can you introduce next speaker?
Hi. Next speaker is Dr. Matthias Steifmann. Dr. Steifmann from Argentina. He's at University of Buenos Aires Medical School and Instituto Cardiovascular de Buenos Aires Interventional Cardiology in 2010 training. He will be talking about experience of TAVI with the VitaFlow valve over Zoom. Thank you, Dr. Steifmann.
Okay, thank you for this invitation. It's my first time virtually in Korea, so it's a pleasure to be there, and also very grateful for this invitation. So I will talk about this device, it's VitaFlow Liberty. I would like to show one case. It's a case in a box, and also show to all of you what is the initial experience in Latin America with this device. So these are my potential conflicts of interest. And first, I would like to show the features, the characteristic of this device. This is a hybrid cell density frame with double layer PAT skewed for better sealing. And also the leaflets are bovine pericardium with anti-calcification treatment. So it's important to remark that in the outflow, there are low density cells. So this enables the deliverability and also the coaxial alignment. And in the inflow, this device has very high density cells. So it gives to the device very strong radial force that is very suitable for calcified anatomies or bicuspid anatomies. So this is the main characteristics. Also, the device has an inner and outer layer skewed, double layer, so it mitigates the PVL. So this is the device itself. And also, these are all the size chart of the device, so you can treat annulus between 17 of diameter to 29. So there are very broad range of treatment for diameters, and also is suitable for Bovine valve in case of 21 Saber. So these are all the size chart that the patient that you can treat. In terms of the delivery system, the main characteristic, the main feature is that is the first motorized system that is recapturable. This allows to make a very precision implantation, very precise implantation. So to retrieve the valve, you can press one button with one-to-one instant response. It's very easy to use. For me, my personal impression is that this delivery system is very stable. It's more stable than other self-expandable devices. So you choose the height of implantation, and the device will keep during all the implantation this height. And also it's 60 French equivalent because it has an integrated sheet as other self-expandable device. So I would like to show to you, all of you, one case to make an idea of what the device is and what it works. This is a male of 77 years old, body mass index of 24, with severe aortic stenosis, symptomatic for the dyspnea, New York Heart Association class 2, and also angina. Previous history, previous disease, CABG in 2004 with Lima to LAD, hypertension, dyslipidemia, diabetes, chronic renal failure in hemodialysis, 3 weeks, 3 times per week, BAH positive with undetectable load, chronic anemia. So it's a very, very ill patient, high risk patients, but the patient has not conduction abnormalities. The echocardiography shows a peak gradient of 73 with velocity, max velocity in the aortic valve of 4.3. So this is the CT analysis with the annulus perimeter of 77. This fit for a 27 beta flow Liberty valve. The LVOT was very similar, 75 of perimeter. The coronary heights are high enough, so there are not any risk of coronary obstruction. Even the sinus of Valsalva are also big enough with average of 30. These are the vascular access, as you can see, very good vascular access, more than 9 millimeters. So this is the case. Usually, and this is for discussion, but usually we do all cases using CAS overlap technique to try to avoid conduction abnormalities using all valves, balloon expandable valves or self-expandable valves. But we see that using beta flow, if we do not use CAS overlap, the risk of pacemaker is higher. So we use with all cases, even beta flow cases, CAS overlap. So first we choose the position that we are going to use to implant the valve, and then we proceed. This balloon comes with the valve, is provided by MicroPort, and it's a very fast inflation and fast deflation balloon. In that case, we are using a pacemaker in the right ventricle, but we use predilatation with a 24 millimeters balloon using rapid pacing. This is very straightforward BAV. And you are going to see now the delivery system. This is the delivery system of VitaFlow. This button, the blue button, is to deliver the valve. Also, you have a on and off button, and this is a manual control in case that fails the battery. Never happened, but if the battery fails, you can deploy the valve manually. And this is the capsule. It's an ethanol capsule, but the nose cone of the valve is very soft. This is important to avoid any damage of the LVOT and the conduction system. It's very soft. this is the advance of the valve with the inline sheet. Also, the beta flow valve provides the wire. This is a pre-shaped wire that is provided also by beta flow. It's a good wire with high support. And you can see here the transition in the ascending aorta is very soft. In case that you have very angulated aorta, you can switch for another high support wire. And this is the implantation technique. Always in cast overlap, we don't have to touch too much the wire. We start to push in the blue buttons if we are happy with the position to start the deployment of the valve. The delivery system comes with one black dot that marks the initial part of the valve, of the THV. So look here, the second operator is pressing the blue button and the valve is flowing 1-to-1. When we are happy, we push the button continually using wire pacing or rapid pacing, and this is a very easy deployment, okay? And also it's very stable. We use, I repeat, always cast overlap and rapid pacing during the second part of the release. We are checking here the position of the valve in case that we have to recapture, but it looks very nice in cast overlap and also in LAO projection. So this is what we see with this valve, no paravalvular leak at all, because the skirt really, really nice. The skirt is very fabulous, and also the radial force of the valve is very high. So usually we do not see any paravalvular leak. And also if we implant the valve in cast overlap, the rate of conduction abnormalities is below 2 digits. So this is the retrieval of the nose cone. This is very similar to other self-expandable devices. Maybe the difference is that we have to recapture the capsule motorized, pressing this button, and this is the final result. No leak, no gradient. As you can see here, this case is edited, but it's like this. It's very easy to deploy. The results are like this, no leak, and for sure it's a device that it's very easy to use. And this is the control by transthoracic echo with no leak and also no gradient. So this is the case, and this is the initial experience in Argentina. This is the first beta flow that we did in August 2021. This was the classical one, not retrievable. And then we start in March 2022 with the beta flow Liberty, that is the resheatable one. And this is what we see. No conduction abnormalities, no PVL, no coronary occlusion, and extremely stable device. So we did initial experience with 28 cases, consecutive aortic stenosis patients treated with beta flow, and all cases were performed by the same proctoring team. The inclusion criteria was symptomatic severe aortic stenosis, and all patients were treated with beta flow and beta flow Liberty, and we use cast overlap technique in all patients. And this is our experience. The first 28 patients, the mean age was almost 80 years, 60%, 50% of male, STS score for 5.5, so moderate STS. As you can see, there are some bicuspid, not too much bicuspid as in Asia. We have less bicuspid than in Asia, 2%, and only one valve in valve, but very high CT Agatston score. and this was the procedural characteristics. All cases were done by transfemoral approach. We use beta flow and also beta flow liberty in the same rate. We did predilatation in 93% of the patient, but the post-dilatation was very rare, only 70%. And the need for reposition of beta flow was only 28%, so it's very stable. And the short-term outcomes of 30 days are very nice. No poor position of valve embolization, no stroke, only one major bleeding on one major vascular complication, and new LVV 60%, but the need of pacemaker implantation using cast overlap technique was very low. So this is very, very good news, because the rate of pacemaker is almost the same of other valves. And also the mean gradient, the hemodynamics was perfect, 6.86 of mean gradient in average. The mortality was 0, and the hospitalization days was 2 days. So to finish, I would like to show to you the comparison that we did with our first beta flow experience with our last patients that we implant with Evolut. And as you can see here, if we compare, trying to put out the learning curve of the beta flow out of this evaluation, the need of pacemaker using cast overlap was the same, using beta flow and using Evolut. So it's not the device, it's the way that we use the device. Thank you for your attention.
Thank you for that presentation. We'll save the questions till the end. Next 2 lectures are going to be presented by Dr. Michael Kang-Ying Lee. He's currently head of cardiology at Queen Elizabeth Hospital in Hong Kong. He's also honorary clinical associate professor at both the University of Hong Kong and the Chinese University of Hong Kong. He graduated from University of Hong Kong and had interventional training at Brigham and Women's Hospital at Harvard Medical School in Boston until 2000. Dr. Lee, please.
Dr. Lee, we cannot hear your voice.
Okay, sorry. Can you hear me?
Okay. Yes.
Okay, sorry. Thank you for the kind introduction. Today I'm going to talk about some of the new devices. One of them is the Jeju Valve that we have been using for the first 2 cases for pure aortic regurgitation. These are my conflicts. As we know, valvular heart disease increases with the aging population. The more elderly the patients, the higher chance that you will be having some sort of valvular heart diseases. So a lot of these actually are mixed valvular diseases. But if you look at the aortic valve in particular, especially when you look at the Chinese patients, actually aortic regurgitation is much more common than aortic stenosis. Even in the China DVD registry that was recently published, the aortic regurgitation at least is not too much less than the aortic stenosis. So you can see this diagram, AR basically might be actually more than aortic stenosis. And it's the same for aortic stenosis and aortic regurgitation. Once the patients having severe aortic regurgitation are asymptomatic, if they develop heart failure, class 3 and 4, then their prognosis would be much worse. So in general, their mortality rate at 10 years is about 34%. But if the patient is symptomatic, they will greatly increase the mortality. And if they are in class 3 and 4, this would increase to about 1/4 of these patients will pass away in 1 year. Treatment-wise, still, if you look at the guidelines, the mainstay of treatment, if medical treatment fails, still surgical AVR is the class 1 indication. And if there are concomitant open heart surgery, then still surgical AVR is the treatment of choice. So TAVI is never in these guidelines for pure AR. Of course, there are a lot of inoperable patients, of very high-risk patients. So if we have to treat these pure AR patients, some of us will retreat to the TAVI devices that we are having nowadays. So if you look at the earlier generation and then the newer generation of the currently available TAVI devices, you can see that, yes, we can do this, but it comes with a lot of complications, especially second valve, residual aortic regurgitation, or actually a lot of these procedures actually are failed procedures. And then if we compare, there are 2 devices available for treatment of pure AR transcatheterly, both the J valve and the Jeju valve, dedicated devices. If you compare this even with the newer generation TAVI devices, other than these 2, you can see that the success rate with dedicated devices is actually much better than the even the newer devices for TAVI. The main problem with pure aortic regurgitation is, unlike aortic stenosis, which has a very, very calcified aortic valve, there is basically no calcium in patients with AR, pure AR, and then a lot of time there will be dilated aortic root and even the ascending aorta. This would actually make the anchoring very, very difficult. The valve tends to migrate or even displaced, and then sometimes may result in a lot more regurgitation than we wanted to. So these are the currently available TAVI devices being used in selected patients. Yes, we can do this, but as I mentioned, there is a higher chance of paravalvular leakage and a higher chance that we would need a second valve. So we have been treating pure AR patients, inoperable patients, back in 2015. This was our case. By then, at that time, we were still using the core valve. As you can see, severe aortic regurgitation. We use 2 pigtails to mark the annulus because we cannot see any calcium, as you can see here. Actually, end result was, I would say, quite satisfactory. If you can see here, not much aortic regurgitation, and the position actually was quite satisfactory. We are happy. We thought that we've been successfully treated this patient even without any calcium. But then 4 hours later in our CCU, we observed ventricular tachycardia and marked decrease in diastolic blood pressure. And then actually the valve migrated down. In this particular case, we have to put in a second valve, snaring the first valve. Although the end result is quite satisfactory, but still the patient will need a second procedure right after the first one, and then end up with 2 valves. And then we have also been using the J valve, but this was at that time still a transapical procedure that we have to ask our surgeons to do it with us in our hybrid OR. This valve received CFDA Chinese approval in 2017. This was one of the cases that we have done in our hybrid OR. Residual aortic regurgitation actually was very, very minimal, but this procedure have to be done transapically. And then the Jeju Valve Trilogy was the first approved TAVI device for AR. Actually, it's approved for AS and AR and received CE mark back in 2021. It has came all the way since 2009 with a lot of modifications, received CE marks for both AS and AR until the current generation of the TF2 system. It's basically a 19-0 frame again, but you can see that the coronary axis, the cell frame, the cell size is very, very large. So this is very favorable for future coronary axis. And then there are 3 porcine pericardial leaflets inside the 19-0 frame. And what's special about this valve is these 3 locators in which the locators can actually get grabs of the cups, the coronary cups, so that you can stabilize the valve and then allow the valve to deploy and then the function of the aortic valve. So basically, what we have to do is to align this valve. The locators have to be aligned with the 3 cups. And if after deployment, if we can align all these, you will have actually very a good sealing and a very stable securement. And then as I mentioned, the coronary access, because of the big cell size, is actually very, very favorable. It comes with 3 sizes, covers basically most of the anatomy, I would say. So it is actually a stepwise deployment of the system. The first deployment is this deflector. You have to actually rotate this deflector and align the position of the catheter with the aortic annulus. And then this controller actually allows you to push forward the whole system. And then you would then try to align the cups by rotating the C-arm so that to make sure that the middle one is really in the front part of the system. If it is at the back, then you will have to rotate. And this rotation has a very, very good top control. So once you rotate, the locators will rotate and then to the position that we would want to. The middle marker, the middle locator have to be in the front part of the whole system. And then actually you advance the controller to allow the locators to get grabs of the coronary cups. And then once we assure the height, then we will actually do a selected cups angiogram just to look at the position of the locators, whether they are in the right, left, and non-coronary cups. Once we are sure, we can actually release the whole system and the valve will be released and will have the function. Then we would continue to retrieve the whole system back to the sheath. You can see that actually this sheath goes all the way to the ascending aorta so that it will actually protect the 3 locators. It will not be caught anywhere along the ascending aorta. And then the whole system will be retrieved and the device will have the function and the position will be very, very stable. This was the first case. It's actually the first case in Asia. 79 years old gentleman. You can see that we don't see any calcium along the aortic annulus. So that if we use the currently available TAVI device, the risk of migration would be actually quite high. So quite a favorable angle for our procedure. And this was the procedure. You can see that the initial angiogram show a severe aortic regurgitation. And then we first of all align the 3 locators. And then once we are aligned, then we have to do separate cups angiogram to make sure the locators are really in the 3 cups. And then we can deploy and the valve will function. You can see that residual aortic regurgitation is really, really minimal. This was the second case. Again, a smaller valve, smaller annulus, again, without any calcium that can be seen, so that the ordinary device would actually make it the procedure a lot more difficult. So we use this angina valve trilogy system to treat this patient. Again, you can see the marked aortic regurgitation on initial angiogram, and then the 3 locators advanced and then align, and then we have to check with separate cups angiogram to make sure that the 3 locators are in the correct cups, and then deploy the valve, and resulting in much reduced, I would say not much residual aortic regurgitation at all. So both patients have been discharged the next day without any complications and no heart block. So there have been a registry data showing that this system have been used quite successfully. This was a German registry involving 95 patients. You can see that they are treating patients with both aortic stenosis and aortic regurgitation. These are the patient profiles with the Euro 2 score 5.8. They are using quite a number of smaller valves and mainly pre-dilatation for the aortic stenosis. We don't really need pre-dilatation for aortic regurgitation. And if you look at their complications, it's actually very, very favorable results, even compared with the currently available TAVI devices that we have. And the resultant paravalvular regurgitation was only none or trivial, very, very few mild, and then no moderate or severe regurgitation at all. One point to note that for this inner valve to treat AR, sometimes you might encounter heart block, and we might need to implant pacemaker for these patients. I think this is something that we still have to address in the future, as compared to aortic stenosis, only 3% pacemaker rate. So to sum up, treatment of aortic regurgitation with TAVI is quite challenging. And if we are using the currently available devices, it would come up with poorer outcomes, I would say. For these patients who are eligible or at high risk for surgical AVR, in the past, we don't have any treatment options for them. And these results with the inner valve actually give confidence to us that the TAVI procedure for AR can save lives and reduce symptoms if we can achieve good results. This inner valve trilogy system is the only approved device for now for both aortic stenosis and aortic regurgitation. And the design of this system is actually good for the AR, for pure AR without calcium, because of the unique mechanism for positioning, securement, as well as the sealing. We have the honor to perform the first 2 cases in Asia in May, and actually confirm that this transfemoral system to treat pure aortic regurgitation is safe and effective. Of course, we need further studies to further prove the safety and efficacy with more patients in a larger cohort and expanded population. Thank you very much for your attention.
Thank you, Dr. Gang. So discussions will be done after all the lectures. Please go ahead to second lecture.
Okay. Let me see if I can share the second. Let me see. Okay, just this one. Okay. So you can see my slides. Okay. So my second lecture is on the, how we can actually optimize TAVI outcomes in.
Can you show the slideshow?
The
slideshow. The slide is looks very small, multiple.
No, it's not that. Let me see. I shared this already. Can you see?
We cannot see in slideshow.
You're in slide sorter view. If you don't mind clicking the slideshow at the bottom.
Yeah, I clicked this. So still slide. Can you see it?
No, we see still the slide sorter view.
Okay, let me see. How can I do this? No. Maybe I share again. Maybe.
Perfect. Working.
Okay. Can see now. Okay. Thank you. So my second talk is on how to optimize TAVI outcomes in patients with small annuli. So this is a particular problem in our locality. we don't really have a common consensus on the cutoff values. What does it mean by small aortic annulus? But usually for our locality or in our center, we will take like annular area less than 400, perimeter less than 72, or the annular diameter less than 23. Or we need a prosthesis which is less than 20 mm in size. So it is more common in Asia and Southern Europe. And actually, if you look at the surgical cohort, this small valve are actually being used in almost 1/3 of their patients. And females are actually counts for the majority of these small annulus patients. And once the surgical valve have been put in, which is a small one, then it would pose a special problem for our future TAVI procedures. So the main problem with small annulus, once we fix it either with surgical AVR or a TAVI, is mainly because of this patient prosthesis mismatch. So once we measure the effective orifice area, if it is too small for that particular patient's body surface area to generate adequate cardiac output to meet the patient's demand, then we will call this patient prosthesis mismatch. And the cutoff values usually is like moderate ppm usually is 0.65 to 0.85 cm square per meter square in a, with the body surface area, and severe means less than 0.65. But once the patient is an obese patient, more than BMI more than 30, then we might need to do some adjustment as in here, which is actually a little different with different guidelines, different recommendations. So this small anatomy is very commonly seen in Asians, Japanese, Asian, Chinese. And the main problem with this small anatomy is that there is a higher chance of annular rupture if we use a little oversized balloon, especially in calcified annulus. Coronary obstruction, a lot of times it would come with the small iliofemoral arteries, vascular complications, and AV conduction disturbance. But still, the main problem will be this patient prosthesis mismatch, which actually increase the mortality and morbidity of these both surgical AVR and TAVI patients. And actually, it would actually increase the structural valve deterioration of both the surgical valve and the TAVI device. So this is our typical patient, female patient. You can see that the annulus average is 19.4 with area 270, perimeter 60. So, and then the small Valsalva and the very borderline STJ. So this might be some of the typical patients that we see in Asia, in Japan, every now and then. If you look at this Japanese data, they compare their size with the European, you can see that they have a smaller aortic annulus, smaller SOV, and a lower coronary height, as well as lower STJ. So most likely, when they have to choose a TAVI device, they would choose a very small TAVI device. If it is balloon expandable, maybe 23, 20, or an absolute device would be 23, 26. So as I mentioned, for small coronary, for small aortic root, there would be higher chance of coronary obstruction, especially when it comes with the low-lying coronaries. And then if we use a little oversized balloon, then a chance of annular rupture will be higher, especially with very calcified and small aortic annulus. But if you look at the surgical cohort, after surgical AVR, if the patient developed patient prosthesis mismatch, then you can see that with severe PPM, their survival actually is lower. There would be more clinical admission because of heart failure, or there would be actually higher chance of redo AVR in the future. So all this comes with severe patient prosthesis mismatch. And if you look at this meta-analysis, you can see that severe PPM actually is a main risk factor for mortality after our TAVI procedure. So both surgical AVR and TAVI procedure we would expect actually higher mortality if the patient develops patient-prosthesis mismatch. If you look at the CoreValve US pivotal high-risk trial, you can see that the highest risk for patients would be for patients with small annulus to develop severe PPM, and then the chance of this happening would be actually higher in the surgical cohort rather than the TAVI cohort, although the TAVI cohort also have a higher PPM in small annulus. And then all these, if it is in small annulus, all these will translate into a higher mortality in this sort of high-risk patients with severe PPM. TVT registry also shows that if patients develop severe PPM, then their chance of mortality or hospital heart failure rehospitalization would be a lot higher than those without severe PPM. And predictors of this severe PPM might include female patients, in particular, valve-in-valve procedure or very small valve size. So if you look at the TAVI small registry, this have been using the self-expanding valve. You can see again, patients with severe PPM, but not moderate PPM, will have a higher chance of mortality as compared to other patients. Ocean TAVI registry is a Japanese registry. They have specifically look at the small and extreme small aortic annulus by using both the self-expanding and balloon expandable valve. You can see that for small aortic annulus less than 23, the chance of severe PPM is actually higher with the balloon expandable valve. And the same for extremely small, less than 21 mm cohort. Again, this balloon expandable valve actually will end up with much more severe patient-prosthesis mismatch. This also translates into a worse hemodynamics for the balloon expandable valve, both in terms of the gradient as well as the aortic valve area. But if you look at the outcomes, the all-cause mortality, actually, this does not make much difference. So I would say, although balloon expandable valves nowadays will result in smaller effective orifice area and higher PPM, but we still don't know what this means because in the long run, we don't see a higher mortality even with higher PPM or smaller effective orifice area. And this compare the balloon expandable valve and self-expanding valve in patients with small annuli. You can see that self-expanding valves will result in a higher chance of paravalvular regurgitation, but balloon expandable valve will result in a higher chance of both moderate and severe patient-prosthesis mismatch. But again, this does not translate into long-term clinical outcomes, mortality, rehospitalization, also valve deterioration is more or less similar between the two cohorts. In the self-expanding valves, if we consider only this self-expanding valves, you can see that those with supraannular function actually would end up with a higher effective orifice area and less PPM. But again, we don't know what this means, how it translates into future clinical events. If we consider the patient as a whole, actually, if the patient is small built, then we are expecting smaller annulus. So for these sort of patients, even if they develop PPM, the clinical outcomes actually would not be actually as worse as those patients with big body build but small aortic annulus. So if you look at this, this is particularly important. They will have a higher chance of severe PPM if the patient is big size but with a small annulus. So we have to be careful with these sort of patients. And then from the Ocean TAVI registry, we can also see that severe PPM actually is associated with more leaflet thrombosis. These have to be investigated more in the future, whether severe PPM actually is associated with increased leaflet thrombosis, in which we have to step up our anticoagulation therapy after TAVI for these patients. So my take-home message is we have to be aware of small annulus during our TAVI procedure. These small annulus actually are more common in Asians, Japanese, Chinese, and then the small annulus in particular will give rise to a lot of problems, patient prosthesis mismatch, annular rupture, coronary obstruction, to name a few. And severe PPM is associated with increased mortality after TAVI and surgical AVR, I would say, increased readmission for heart failure, and also increased reduced SAVR or TAVI. And it might be associated with early leaflet thrombosis. We can achieve better hemodynamics with self-expanding valves, especially with the supraannular design, but there have been inconsistent data on the critical outcomes after a self-expanding valve, a balloon expanding valve for small aortic annulus. So my way to prevent PPM is, I tend to use more of the self-expanding valve if the annulus is really small. And then I tend to do a lot more post-dilatation just to maximize or optimize the valve for future benefit of these patients, especially when we move to younger, lower risk patients. Thank you.
Thank you, Dr. Lee, for your excellent lecture and doing 2 lectures. And
Thank you.
these all 5 excellent lectures are open to discussion. We have the 6 panels, Dr. Kang Ji-yoon, Park Man-won, Park Sang-don, Soyoung-hoon, Yang In-ho, and Jang Jae-hyuk. So please feel free to raise question or comment.
Yes, may I start first? My name is Jim Kang. I'm from Seoul National University, and I would like to have the question for Dr. Pa, please. Your talk was very impressive about the role of TAVI in young age patients. Can I understand? I have 2 questions actually. The first is, can I understand that the more importance of an ideal heart team may be more important in younger patients because these patients have to decide whether to receive surgery or TAVI, and if they receive surgery, if they should have any aortic root modification for future TAVI or else. And in the old patients, there's relatively lesser issues that we should consider when we proceed for TAVI.
Yeah, I totally agree. I think if you're dealing with a 97-year-old patient who's minimally active, surgery is not an option for them. I think in the younger patients, that's where the biggest consideration of surgery and surgical technique should be. And I think that the advanced techniques that we talked about, which are little used these days, partially because they're only used in other pathologies, apply a lot more to young people. And I think that the value that we can bring as cardiologists is having the discussion with the surgical colleagues about who would benefit from those techniques. And then it's, together we can quantify the risk for those patients and determine what the best solution is together. And I think the valve team works best where everybody works together. And there's no reason for us to send patients to surgery without involvement of the valve team and send patients to TAVR only with the valve team. So I think the valve team is essential at all levels, and CT scan should be done at all levels.
The second question is about your issue about coronary alignment and commissure alignment. Of course, the coronary access is a major issue that we should achieve commissure alignment, but the annulus at the annulus level is not a circle, and there is native commissures, and there's a geometry of the original annulus. So to my opinion, I think that even if the coronaries are not at the middle part of the sinus, the commissure alignment may be more important to maintain the natural geometry of the patient. And actually, as interventional cardiologists, we have minimal difficulty in engaging slightly abnormal coronary osteums. So commercial alignment versus coronary alignment.
Yeah, so I think that it depends very much on what valve you're going to put in there. I think if you're looking at the larger evolute sizes, the level of risk for around the commissural post, it's pretty wide. The angle of risk is pretty wide. So that's when it's important to be very closely aligned. If that wasn't an issue, I would agree with you. And there is some data that if you achieve commissural alignment, perhaps you decrease the risk of sinus thrombosis and flow dynamics are better. But I think this is a work in progress, and I think we're going to hear a lot more about this. And finally, so far we haven't had balloon expandable commissural alignment, but with the X4 valve, which is the next generation of Sapien, hopefully that will be achieved. The problem, however, with commissural alignment is that if it requires a lot of manipulation in the root, that can be problematic as well because it may increase your risk of stroke.
Dr. Lee, I have two questions. Actually, I was surprised the Jeju valve can be used in both severe AS and also the severe AR patient. So in Hong Kong, the Jeju valve did get approval for can be used in both severe AS or severe AR patient, right?
Yeah, yes, we actually follow the CE mark approval. It was approved by CE mark back in 2021 to treat both AS and AR. But because of the limitation of the devices, it's very, very difficult to get the device worldwide. So we reserve the device to treat our AR patients for now. We have not treated our AS patients with this device in Hong Kong yet.
Why did AR patient showed very high rate of pacemaker implantation than compared to the severe AS patient in applying Jeju valve? So can you explain the difference?
Yeah, I think because in AR patients, even with this valve, the recommendation from our proctors is still a little more oversizing than our usual TAVI device to treat AS patients. So I think, first of all, oversizing is one of the contributing factors. And then you can see, actually, we push the 3 locators to the bottom of the coronary cups so that when you expand, actually, it's not really in a high position. I would say it's actually quite deep, at least 8 to 10 mm below the annulus. So if the membranous septum is short, then it might increase the chance of pacemaker implantation in the future. So what I have suggested to them is we try to implant higher. Although the proctors might not agree with me, next time we might try to implant higher. I do not push the 3 locators way down to the cups and see if this can actually reduce the chance of pacemaker in the future. That's something we have to explore more in the future.
Dr. Lee, may I ask you a question? When we see the morphology of Jeju valve or trilogy,
Yes.
locators are really important component to prevent regurgitation, just embolization toward left ventricle, as well as distal embolization.
Yes.
But in terms of prevention of prolapse to LV, locator is definitely strong. But I'm a little bit concerned about the clasping power of locator to clasp the valve leaflet and prevent distal embolization. If you implant Jeju valve trilogy a little bit higher position, such kind of clasp force may be weaker. Is there any chance of distal embolization when you study the cohort registry of Jeju valve or trilogy?
I don't see any of the reported cases. Of course, that's the real worry. So that's why even with the proctors, with the company, they ask us to push the locators as deep down into the cups as possible. What I mean is try to like grasp enough so that maybe in the lower 1/3, then if we deploy, the chance of pacemaker might be lower. But this is something we don't know. We have to explore. But you are right, Dr. Kim. If the locators are too high, then you might not grasp enough of the cups, and then the valve might have a chance to embolize upwards or downwards. But I don't really see a lot of reported cases even in the registry.
Dr. Matthias, I have a question. So I was surprised by your presentation. The beta flow have many advantages. First, very stable deployment process, and then very low pacemaker implantation rate and very easy coronary access. So if you have experience in Evolut R or the other self-expandable valves, so can you compare the performance of these valves, the beta flow, compared to other self-expandable valves?
Yes, absolutely. This is a very good question because both valves or all self-expandable valves have some point of contact, some similarities. But in this case, what we find in beta flow, the difference is the stability of the implantation. When you put a core valve, Evolut, or other self-expandable device as Accurate Neo, there are some movements during the final part of the release. Even with Evolut, we can see some upwards or downwards movements during the final part of the release. And that, in my opinion, is because of the shape of the device is not straight. The shape of the Evolut R, and we have seen this in aortic regurgitation case that have been shown by Dr. Lee. The shape of the Evolut R is not straight; it's tapered. So in this case, the beta flow device has a very straight shape in the inflow, and also the motorized system is very stable. So in the final part of the release, when you choose the final depth of the implantation, this valve is very stable. So if you choose to put the valve very high, this valve will keep this depth. So in my opinion, this is the main characteristic. And also because the valve, the beta flow is very straight in all dimensions, from the smallest valve to the biggest valve. Also, there are some experience in aortic regurgitation using beta flow, and that's why, because it's stable, it's straight, and the radial force is very strong, and that is for me the main difference between other self-expandable devices.
I have a question to Dr. Matthias. Mucho gusto. Bienvenido a Jeju Valve. Gracias por su muy buena presentación. Yo tengo una pregunta.
Muchas gracias.
Yeah, I have a question. You did pre-dilatation in most cases in beta valve, right? And you showed us the lower instance of pacemaker instance compared to Evolut R. This means that the radial pulse of the vital flow is much soft than Evolut R, or no? Yeah. How do you feel the radial pulse?
No. I think that the radial force is bigger in beta flow, is bigger than other self-expandable valve. I think that is the self-expandable valve with biggest radial force. But I think that there was no difference between evolute and beta flow in terms of conduction abnormalities. But what we want to show is that if we use gas overlap technique, we can obtain the same conduction abnormality rate with beta flow than other valves. Because if you think that you are using a valve that have more radial strength, maybe you can think that it comes with more pacemaker rate, but it's not like this, and that is one I want to show. If you use the correct gas overlap technique and you plant the valve, this valve in gas overlap technique, the rate of pacemaker is almost the same that other valves, but the radial strength is bigger.
Matthias, I have a question regarding your VitaFlow Liberty valve. You mentioned the morphology a little bit different from the Evolute series, but that was after deployment. During deployment, how is it stable than Evolute? Just motorized deployment, manual deployment, I don't see any big difference between two styles regarding the movement, downward or upward movement during deployment. Is there any other hidden secret for the stabilization during deployment, such as central spine structure or other hidden secret? I don't believe just motorized deployment is a kind of key factor to stabilize the valve system during deployment.
It's a good point. I think that it's a combination of things. What we find in the motorized system is that there are some transfers of the movement of the second operator. When the second operator opens the valves in some part quickly, there are some transfers of the movement of the second operator to the first operator. And this is one point. When you press the button, there are no transfers of movements. And the second point is not because of the delivery. I think that is a combination of the device, the shape of the device, and also the radial force of the device. In my opinion, I have not the answer because I'm not involved in the device and the construction of the valve. But what I feel, because I have done 55 or more, almost 60 cases, and my feeling is that it's very stable. I have not bad experience in terms of embolization. Usually, we don't need to reposition the valve. The need of reposition is less than other devices. So I think that there are not one factor that make this device more stable. I think that it's a combination of factors. Some factors are the delivery, some factors are the device, and some factors are that we get this device with a bigger learning curve of other devices. So we are using this device with high experience with other devices. So maybe these all things combined make that impression.
So any questions from the floor? So I like to ask you, Dr. Pop. So in Korea, the heart team discussion is a mandatory step to get reimbursement. So, but your team do all the heart team discussion in patient receiving SABA or TABA. So is the in United States most hospitals adopt this kind of heart team discussion, or in your hospital?
So in our hospital, we have a very good relationship with our surgical colleagues, and we do discuss all cases, whether they go for surgery or whether they go for TAVI. That's certainly not the standard in the United States. I think it should be the standard. I think care for the patients would be a lot better. There is talk in the United States of actually no longer requiring two operators, a cardiologist and a surgeon, and I think that that's a major problem, because I think that by far the most important thing that we got out of TAVI has been the fact that we're finally working together with the surgeons, and I think that's a wonderful thing that should be encouraged.
Thank you all the speakers and panels
Dr.
and
Zhang,
yeah. Oh,
can I have just one brief question
okay.
for Dr. Pop? Dr. Pop, I deeply moved your nice lectures. I have just one question about the heart team discussion process in United States. Actually, in Korea, the heart team discussion is one kind of mandatory process to do TAVI. It's actually little bit, unfair decision system for interventional cardiologists compared to the surgeon. So anyway, we are struggling this kind of, some official the steps. But anyway, we will understand that, we will choose the best option to treatment for patient. But in Korea, there is some kind of, some composition of two cardiovascular surgeons and then two interventional cardiologists and echocardiography step and radiology step and then the anesthesiology step. If there is just, even just one rejection to do TAVI, it is impossible to do TAVI actually. How about the condition in US? If there is some kind of discordant opinion in between the doctors, is there any kind of options to do TAVI in United States?
Yeah, so technically we have to have the agreement of a surgeon and a cardiologist to move ahead. The reality is that I think the valve team works the best when everybody has the patient's best interest at heart. And I think the way to get to this is to not fight with one another, but rather look at that. My most recent case that was sent for surgery would have been probably sent to TAVR in a lot of other centers in the U.S. Was a 69-year-old woman who was morbidly obese and had a very small annulus. She wasn't Asian, but she had an extremely small annulus. And had she not had a CT ahead of time, she would have probably had her chest opened, and once they realized on the table that she needed a 19-millimeter valve, she would have gotten a trifecta valve. In this case, we actually stopped and we talked to the surgeons and said, despite the fact that the patient is 69 and despite the fact that she was told that she would probably get a TAVR, we recommended to the patient that she get surgery. And it's a much stronger recommendation when it comes from a cardiologist than it comes purely from a surgeon. And I think we have that level of relationship that the surgeons know that we will send to surgery patients who would benefit from surgery, and conversely, they will send to TAVR patients that would benefit from TAVR regardless of age. So we're really looking at a patient benefit.
Okay, Dr. Pop, just one more question. Is there any room to do opinion from patient themselves or their family guardians? Actually, there is no process in the shared decision making in Korean heart team discussions. It only depends on the decision of the doctors. And so there is no room for patient or guardians. And so is there any room to get in the interrogation with the patient and family members, the preference?
Yeah, there is certainly a lot of role for patient preference. That being said, I think the situations where I've gotten most in trouble and I've gotten the most complications have been situations where patients have gone against the valve team decision. And in our situation, we said, if we make a recommendation and the patient doesn't take that recommendation as a team, then we tell them rather go somewhere else and get your procedure done somewhere else. We're not going to do the right thing, the wrong thing. But I think obviously patient preference has to be taken into account, and it's very important.
Okay, thank you.
Your answer is you achieve 100% agreement. The real question is, if you cannot reach agreement, how can you do? That was the question.
Yeah, so if we don't achieve agreement, then we stop. And The most recent example that I had, we had a cardiologist who's on our team, and we're trying to be very democratic. And the cardiologist absolutely insisted on doing a procedure in a patient where we felt it was not recommended. And the surgeon actually refused to sign the consult, which blocked the procedure. We had a long discussion, and finally the cardiologist relented, and we were able to get an MRI to prove whether the procedure is necessary or not. But I think it's, we've never ever taken a vote in the valve team. We always try to achieve consensus. And unfortunately, you know, it depends very much on the personalities. But I think that that's where the guidelines have to be adjusted to reflect the importance of the valve team for going forward. I think it's tough when you have the surgeon being the ultimate decision maker. I think it's much better to have the entire team being the decision maker.
Making a friendly heart team is the answer. Yeah. Yeah, very hot the discussions. The session went by very quickly because it was very fun. So I like thank Dr. Matthias and Dr. Lee and also Dr. Andre Pap. So thank you. We have to close this session. See you this fall or next year by another symposium. See you. Thank you.
Thank you.
Thank you very much.